Thanks, Larry. I don't know about you, but this meeting is one of the best meetings I come to. It's a wide range of topics, from deep biology to a whole ton of different things. And one year you showed, I can't remember the name of that cartoonist with all those complicated machines. And coming to this meeting is like looking at one of those, like looking at the inside of your head. So I'm thrilled to be back after the last few years that have been a little uncomfortable at times. And it's great to be with you all. My name's Simon Lovestone, for what it's worth, and I'm going to be moderating the first session. We've got 4 fantastic speakers. I'm not going to read out their bios to you. They're all in the book, but we're going to be starting with Bill Martin. So Bill is global lead for neuroscience, an end-to-end job from really early discovery through to post-marketing of compounds. He's head of neuroscience at Janssen. And the other thing you need to know about Bill is that he's my boss. So Bill has 2.5 hours to speak. And I mean, just a little, this is going to embarrass Bill, but when you get to my age, I've worked with a lot of people, a lot of senior leaders. I've worked with some fantastic people. And Bill is up there amongst the very best. And one of the things I like most about working with Bill is he is a scientist's scientist. So he does deep science, he's rigorous, he really knows the field, he reads scientific papers. He's also entrepreneurial, and that's something that maybe you don't often get so much in big pharma, but he's a truly entrepreneurial scientist as well as a great scientist. And he has wide ranges of interest. Does that remind you of anybody? And so I've been enthusing about this meeting to Bill for the last, 3 years or so that we've been working together. And as a consequence of that enthusing, I said, I'll have a word with Larry. You'll come along and listen, see if you think it's as good a meeting as I had. What I didn't realize, but I should have thought this one through, is that Bill would end up talking and I would end up moderating. Anyway, I know we're both pleased to be here. And Bill, let me ask you to come and tell us why the map is not the territory and how neuroscience is changing. Bill Martin.
Thanks, Simon. I am truly delighted to be here. This is, as Simon said, I've been hearing about this meeting for so long that it added pressure because one wants to obviously come to a meeting, put in the time, and know that it's worth the time. And it's more pressure when I have to actually make sure that I make this meeting as good as it can be. So I'm deeply humbled to be able to kick off this symposium with this talk. So thank you for including me this year and for inviting me. Let me move on. So the overview of this presentation, it'll be kind of in 2 parts, but there's 4 kind of themes, if you will. I'll talk about the promise of precision neuroscience. Over the course of my career, I don't think there's been a more exciting time to be in the field of neuroscience, and that's not an exaggeration. I hope you get a sense of why that's true today. It's important to know kind of where we've come from. So a little bit on the history of the classification and treatment of serious mental illness, the emergence of biological psychiatry, which might surprise you, is not last year, 5 years ago, but 70 years ago. And therefore, we could ask the question, well, what went wrong? If we actually had the foundations of biological psychiatry so long ago, what's taken us so long to come to where we are today? And then the last part will be sharing with you, the notion of a new framework for computational psychiatry-informed classification of these very serious disorders. Right up front, there we go. Right up front, I want to just give you a sense of maybe the 3 things that you'll take away. If you doze off, haven't had your coffee, whatever, you'll feel covered just by saying, oh yeah, Bill talked about how our progress towards a truth in neuropsychiatry has stalled. And what I mean by that is the biological basis of disease. The categorical definitions that we have today limit our ability to generate insights into the mechanisms that underlie these conditions. But the optimism is around our advances in brain imaging, data science, and the tools of precision medicine in general that truly can enable this foundational shift in our understanding of CNS conditions. So why precision neuroscience and why now? Let's just really quickly, I know that we're under pressure, keep losing time of my 2.5 hours, but no one needs to be reminded of the global burden of CNS diseases. These are high and rising in an alarming way. And what we know is that brain disorders are the leading contributors to global disease burden, according to the World Health Organization. Dementia incidence outpaces all disorders. And in the US, the economic burden of dementia is 12 times that of cancer. It's something that we have to keep talking about, because to make progress here, we have to do this together and recognize the seriousness of where we are. And specifically, depressive disorders, the single largest source of the disability-adjusted life years. So you would think with that global burden high and rising, that the commitment to developing new therapeutics would be strong. And I would characterize it as fragile but persistent. So certainly, 12, 13 years ago, there were greater than 300 medicines in development for mental illnesses. You see that drop off down to just over 100 in 2018, 5 years ago. And over that course of time, you had large pharma really back away from this commitment to CNS disorders. And I'm not sure they were wrong. They backed away because in the setting of everything that one could do, how is it that you could put resources behind something where there was not a strong biological basis? Oops. I don't know what's going on. Somebody else is controlling that? Is that what it is? Yeah. Okay. Is there something I'm doing? No. Okay. So the understanding is that, we weren't sure how to make progress, and so many companies just backed away. But what we've seen is actually this reemergence, this sea change. And I think you hear a lot about how precision medicine can now be brought to neuroscience. And for all of these companies, whether they're large and established that are coming back into neuroscience, or the new companies that are forming, you see many of those who are describing their strategy as describing the precision approaches to neuroscience. Now that sounds great. The use of precision medicine principles depends upon measurement of biological characteristics, which when targeted might yield improved treatment responses. Now, driver for this aspirational future state is the belief that we now have the increased ability to harness and aggregate new data sources concerning the manifestation of disease and treatment of those diseases. And the idea that identifying specific genes, biomarkers, or other factors that will enable us to sort of parse this, that will enable us to design more precise interventions to alleviate disease, is really at the core of the promise. But it's important to recognize that this requires innovations in clinical trial design, in patient monitoring, biomarker discovery, and data science. And it requires the ability to compare treatments numerically and to develop statistical tools for really moving the field forward, going back and forth between individual and aggregate data, and that's something that we need to keep in mind. So the concern, is to me, is that we could overpromise and underdeliver. That with all of this promise, you see the conventional approach, we're going to get the right treatment, the right person at the right time. The persistent approach is we're going to use biomarker discovery, data science, and clinical trial innovation. And then magically, we're going to have this optimized set of therapies. The problem is we do not have a therapy optimization problem. There aren't just mismatches between patient diagnosis and available treatments. We need to move from a variety of patient types to discrete patient subtypes. And to do that is non-trivial, because ultimately it requires us to reconceptualize these established categories. And lastly, the pillars of the promise of precision, biomarker discovery, data science, and innovative trial designs, these have not yet come together. They've not yet coalesced in a way that can help us make real progress. So let me quickly fly by how we got to where we are, because I think it's important to recognize that how we've classified diseases goes a long way to how we treat them. I call this the modern history of managing psychiatric conditions because, there's really three phases, if you will. Institutions, interventional neurology, brief, troubling, but still present, and then psychopharmacology. These three phases really define how we've come to where we are. 560,000 patients were in mental hospitals in 1955 in the US. This is what led to, the interventional neurology period, the frontal lobotomies. 40,000 people were lobotomized. As grotesque and disturbing as that seems and was, recognize that they were responding to the notion that behavioral manifestations, abnormal behavior, could be considered as a reflection of connections in the brain. What they're trying to do is sever those connections. And fortunately, that period was short-lived because of the advent of psychopharmacology with chlorpromazine. And what one saw over the ensuing 30 years is a massive hospitalization rate drop by 80%. So the institutions and the medicalization of mental illness is actually non-trivial because there's a time, going back to 17th century, where all of these conditions were just considered conditions of moral weakness, had nothing to do with the brain. And fortunately, there were individuals who recognized that you could study these people. There's disordered thought, there's auditory hallucinations, there's memory impairment. And what you saw with Dr. John Haslam is he captured these detailed patient histories and published those patient histories. He was one of the first to talk about the brain basis of disease, and called it disease. We subsequently called it disorder. He called it disease. He shifted from even insanity into more kind of precise, if you will, subtypes around melancholy and things like that. But the notion of describing a form of insanity that occurs in young persons connected with a loss of memory, is something that actually we carried forward as a field. Now, subsequently, 100 years later, classification systems started to emerge, and Maynard, who everyone as a neuroscientist will know for his work around sort of structural biology, right idea, wrong time. He went out of his way to try to link, the structural changes in the brain with the mental diseases of the day, and frankly failed. It was simply the wrong time. You didn't have the advent of a microtome. There was a lack of sort of reproducibility, staining techniques, all of those different things. And unfortunately, what that led to was his denouncement by Kraepelin, who called, everything, Maynard sort of having a brain mythology. And instead, Kraepelin focused on the quantitative observation of clinical research. And what he did was basically the basis for what we now have as our modern diagnostic classification system over 100 years ago. And so this part is important, that if you consider two different subpopulations of individuals with neurological conditions, one, pre-senile dementia. These are individuals who have problems with memory and language, disorientation, hallucinations, with an onset in their 50s. Compared to another, premature dementia, chronic deteriorating psychotic disorder characterized by rapid cognitive disintegration and onset in the late teens and early adulthood. And as you know, in the one instance, because onset was later in life, post-mortem tissue could be harvested. There's a neuropathological basis for what we now call Alzheimer's disease, where the other, early onset, there was no mapping to the brain. And so this is what led to the Diagnostic and Statistical Manual 1, 1952. Both of those were in there, Alzheimer's disease and schizophrenia. One listed under chronic brain disorders, the other, disorders of psychogenic origin without clearly defined physical causes or structural changes in the brain. So imagine if in 1950-52, we actually had the tools to see into that neuropathology. We actually had the imaging capability to do that. The course of the research agendas over the next 70 years may well have been different. But we didn't. And so what we had was a classification that really set the course for the research agendas around both neurodegenerative and neuropsychiatric conditions. In the case of Alzheimer's disease, we've come to appreciate it, that it exists along a continuum, that there's a clinical biological construct where we understand the mechanisms that contribute to onset and progression of disease, whereas in schizophrenia, recognized then as now as a spectrum disorder. And as such, what we saw was the increasing, if you will, refinement of these subsets of schizophrenia into these smaller portions, all of which based solely on clinical observation. So what that meant was the field in neuropsychiatry, schizophrenia and depression, was left to search for these biological hallmarks for categorical spectrum disorders that themselves must have been more than one disorder. So if you consider that the foundations of biological psychiatry were in place and began to emerge in about 70 years ago, as I said, why haven't we made more progress? I want to briefly review sort of three components. I've limited myself to a 20-year span here. 2 books and 1 medicine that really wound up being very influential then and I think are still influential today. I'll start in the middle. So the idea with a medicine that followed chlorpromazine, haldol, really was the first to introduce the concept of brain basis for symptom control, and as I'll go on to, was the foundation for rational drug design. There are 2 other publications, 20 years apart, one by HEB, the Organization of Behavior, many will know as neuroscientists, relating neural activity to behavior, and the other, a computational modeling framework published in 1969 on studying the brain-behavior relationships by Papert and Minsky. And just for context, this is where both DSM sat and where the discoveries of Watson and Crick sat. So you have the emergence of biology. There was a shift in how we thought about psychiatry, but it came within a field amidst of this classification system and emerging understanding of genetics. So really quickly, I'll just say that the idea of having a systematic approach to treating brain disorders, it emerged. It's not just chlorpromazine, which was a serendipitous finding, but the observation that Belgian cyclists who were taking amphetamine doping for performance would basically exit their bike with these psychotic, schizophrenia-like behaviors was the catalyst for actually initiating a whole field of research where you could administer amphetamine to rodents and look for the ability to block those behavioral responses. And it led to the production of typical and atypical antipsychotics, more than 17 of which came from Janssen during that era up until today. So on the one hand, as we said, got people out of hospitals. One could argue whether that's a good or bad thing, but certainly provided a shift in people's ability to function that we should applaud. It also set the course for psychopharmacology in general. And the bad side of that, if you will, is that in characterizing these treatments as antipsychotics, antidepressants, anti-anxiety, it did 2 things. First of all, it actually made the labels, psychosis, depression, whatever, anxiety, something to appear as if they're biological constructs, when of course they're not. They weren't antibacterials that were going after specific bacteria or fungal. They were anti-some behavior. The second part, of course, is what started as an antipsychotic or antidepressant, they wound up being used across all of the indications. And so it goes from helpful from a clinical standpoint to harmful from a scientific standpoint because it began to lock us into a way of thinking, the anti-something that was not actually biologically based. And yet, this is what we still do. Report from 2023, we're still making medicines for anxiety disorders, ADHD, bipolar depression, schizophrenia. And to me, this is we've come to the point where we simply need, if everything worked great, that would be fine. But of course it doesn't. There's still massive unmet need, folks who are left behind, and we simply need to do better, and we need better frameworks to develop better treatments. Now, the field of Alzheimer's stands in stark contrast to the field of neuropsychiatry, where in Alzheimer's, obviously, we talked about a neuropathological basis that was at the core of the disease. Neuropsychiatric disorders, the constructs themselves, you see that there's massive genetic overlap across these disorders. the symptom overlap is present in such a way that comorbidity is actually the rule, not the exception. And there's no systematic overlap between genes and behavioral symptoms. So we're searching for something, a biological basis for a thing, that actually is not likely to exist as the way we've conceptualized it. And to me, this signals the importance of shifting from understanding the category, fill in the blank, whatever the category is, to identifying the multimodal predictive and prognostic biomarkers that are the biologically defined subtypes within the spectrum of these disorders. And this is the part where there's a book from 2022. I'm at an academic institution. I will admit the unscholarly nature of me of singling out this book that was published last year. It's a book that I haven't read. But it's this inspiration for this particular title of this talk because it's this type of book. And you can look at some of the chapter titles: schizophrenia, genomics, genetics of bipolar disorder, genetics of depression. We're doing the same thing over and over again. And this is the part where we've allowed the description of the thing, schizophrenia, bipolar, to become the thing itself. We've allowed the model of a condition. It's an important model. Clinical symptoms are real. But the model of the condition is not the thing itself. It can't be reified and treated as if it's real. And paradoxically, by applying the modern tools of biology, genetics, genomics, multi-omics, systems biology, all of those different things, to these concepts, we run the risk of becoming precise without being accurate. We run the risk of actually having our understanding being refined, but being further removed from the biological basis of disease. And that's why the time is now to really shift our thinking and how we approach the neuropsychiatric conditions. So I'd ask, how is it that Alzheimer's advanced while neuropsychiatry languished? Same time, classification system, all those different things. And yet there was something special about it that I don't think was just by accident. So I put this together as a notion of the ability to triangulate our understanding of Alzheimer's disease both was informed by and yielded a new conceptual framework. And it was relatively simple in the sense that we had the ability to relate cognitive impairment to brain imaging measures, which yielded these mechanistic insights. We had the ability to relate the pathology to CSF measures and genetic markers to yield diagnostic insights. And the breakthroughs in the development of these highly accurate fluid and neuroimaging-based biomarkers did not simply happen. They occurred within a conceptual framework of Alzheimer's disease that related amyloid pathology, tau pathology, and neurodegeneration to patients over time. Hypotheses could be formed, tested, refined, discarded, all while contributing to a shift from this traditional clinical symptom-based description to one that is a clinical biological construct of disease along a continuum. So I ask, could we do the same in neuropsychiatry? Rather than trying to borrow from the field of oncology, which is clearly different, let's take advantage of what the brain offers. Take advantage of its unique features, as well as the emerging tools and technologies, and really, within the context of the work that was already been done in biological psychiatry, go back and say, now's the time to do it a different way. So what I'll try to cover, not sure how we're doing on time, is the notion that we can begin to elaborate these disorders into diseases. We can begin to shift from a spectrum of clinical symptoms into subsets of biologically based subtypes. And probably not perfect, but just borrowing from Alzheimer's, let's do the same thing. Let's look at clinical symptoms, brain measures, and fluid measures to really guide this. And we can do this by leveraging the concept of the connectome. So the concept of the connectome is super simple. It just denotes the sum of connections between neurons in the nervous system. And like the genome, it implies a completeness. And the connectome, provides a fingerprint of identity, if you will, that reveals, some of the specificity, the uniqueness of who we are. And Sebastian Sung, really says that we're different because our connectomes differ from one another. And we know that neurons, for example, can reweight their connections, strengthening or weakening them under certain conditions. That's why you form habits, whether those habits are good or bad. So the notion of neural activity and connectivity as the basis for thinking about understanding the brain disorders is something that was obviously hypothesized back during the Hebb era in 1949, but we didn't have the tools to really do it. So Hebb talked about relating neural activity to behavior. The nature of synaptic transmission is not simply linear, apparently always involves some closed or recurrent circuits. Even talked about the nature of mental illness, the role of cortical synchrony and remission from depression. The establishment of hypersynchrony would provide a pacemaker to correct the disorganized firing of cerebral neurons. And what I like most around this idea of connectionism is that it assumed that assembly depends on a very delicate timing, which might be disturbed by metabolic changes as well as sensory events that do not accord to sort of pre-existent central process. So they're misaligned. And I like this part. When they're transient, it's called an emotional disturbance. And when they're chronic, we call it neurosis or psychosis. So quite simply, could we now begin to use these same insights to relate brain activities to behavior? And to do that, we can leverage advances in functional MRI to map the functional connectivity of these large-scale brain networks. I want to go into a lot of details here. The talk starts to get a little bit heavy, but it's not. The details don't matter if you bear with me. What I do want to relate is some of the core components. First is that we can now understand resting state activity by placing, this is looking at a bold signal, you place one sort of seed, if you will, somehow shown in the black dot. I don't know if that's possible, right here. And then you ask, which brain regions are connected to, if you will, functionally connected to those by looking at oscillations in that signal. From that, we can move to identifying these intrinsic functional networks that themselves have names that we've put on them based on brain locations and what we believe they subserve. And then lastly, we can look at a whole brain level the ways in which these networks interact with each other. So this provides a new opening for us to begin to think about how we can move from the brain disorders that are defined by clinical symptoms to actually flipping it and ask, can we define brain disorders by a dysregulation of brain circuits, even if we can't define the brain disorders themselves? So how would we do that? So symptoms still matter. They generate the brain-wide pattern. We can parse that pattern as I just described. We can even look at behavioral tasks to actually get some refinement, apply machine learning approaches, and arrive at sort of multivariate classifications that can give us a sense of healthy versus not healthy, maybe without the labels. So given the heterogeneity and comorbidity of something like depression, major depressive disorder, or schizophrenia, can we define these disorders using these approaches? And the optimist in me says yes, but the pragmatist in me says only if we incorporate computational approaches. So we go back to the notion of the percepton. This provided a computational modeling framework for studying brain behavior relationships. It's the third and final pillar that we talked about in biological psychiatry, as a basis of biological psychiatry. Perceptons were the simplest machines. And Minsky and Papert in their seminal work from 1969, they consolidated some of the thinking at the time as the power of computing was beginning to emerge. And grounded in the original thinking in perceptons, they provided a framework for the basis of pattern recognition, learning machines, and threshold logic, all of which obviously echo the work of Hebb and which are clearly relevant for the work that we're doing today. So taken together, we can actually use this type of approach to study brain behavior relationships and look at this in two different ways. One at a sort of local circuit level and the other at a more large functional circuit level. So ambitious, because I'm not sure how much time I have left, but I'd like to try to cover 5 examples. There's a trade-off of depth and breadth here, but I want to relate sort of how the example approaches have emerged from the literature over the last 5-10 years, which really provide the basis for us to refine and redefine these neuropsychiatric conditions. I'll cover one in depression that's relating resting state global connectivity measures to define clinical subtypes. I'll try to cover two in schizophrenia, one a pure model-based approach, and the other one looking at sort of symptoms to circuits. And then the last two will be around a transdiagnostic approach, one with the brain imaging approach and one without brain imaging. So, and I should say there are caveats to all of this, right? You could say, well, each paper could be picked apart for its individual weaknesses. That's not what I'm going to do here. I think it is worth doing that. We don't have all the methodology worked out. There's not full alignment. But I think in the totality, let's look at the reinforcing themes that emerge from these papers and trust some of the science that's emerging. So the first is work from from Connor Liston and Drysdale, published back in 2016 now. Feels like forever ago. What they did was they looked at these different regions of interest. You can see that the color-coded dots here. Oops, wrong one. On the surface of the brain here, each color-coded dot represents a different sort of functional network that we talked about. And then what they did was they mapped this against, they also show a sort of full matrix of the interaction of those networks. So the way they accomplished this was they looked at imaging sort of patterns across individuals. And there was a training set and a test set. We're not going to get into this. But they used an approach to basically relate the patterns of connectivity with the symptom profiles. And then they clustered these individuals according to the connectivity patterns and the components. And interestingly, kind of not shown here, but they showed that depression and anxiety patterns were overlapping, but depression and schizophrenia patterns were not. So there is a brain basis here for the distinctions that we see. I'll skip over some of the details on which networks were sort of affected and actually move into this component. Because I think the really cool part of what they've done here is they look at the relationship between the clinical features and the connectivity features, and they can identify an anhedonia-related component. You see here the rank order. So it means there's a pattern of brain activities in individuals in aggregate that seem to confer a higher prevalence of anhedonia. And likewise, one can show the same for anxiety. So the fact is that the brain sees differences, sees these subtypes of depression. They are biologically based, and as long as we can move beyond the historical categories, we can probably transcend those diagnostic borders, those boundaries. Another super cool approach, this is in schizophrenia, and now taking this kind of model-based approach, which is almost directly this kind of perceptron concept, is using a model-based clustering approach and dynamical systems to look at how a specific brain network interacts in the setting of a particular task in individuals who are either healthy or who have schizophrenia, who've been diagnosed with schizophrenia. The model consists of visual, parietal, and prefrontal regions, not super important. The key is that they first show that the clustering solution they have defines 3 subtypes of patients with schizophrenia. That's probably what one intuitively would say. What's important is understanding that each of those subtypes actually have different patterns of activity just within these local circuits. And so specifically this first and third group, they showed a strengthening of the visual prefrontal pathway. And the prefrontal and parietal connections were increasing under the increased working memory demands as a working memory task that they use. But the relative strengths of these were reversed. And so if you look at the 3 groups shown on the right-hand side, what you see is the cluster 2 showed the sort of same degree of negative symptoms, so-called negative symptoms of schizophrenia, as the healthy controls. Cluster 1 showed less, and cluster 3 showed a lot more. So, this is a way of shifting how we think about classification, looking solely at behavioral tasks and responses to a specific, brain circuit. One can actually report the subtypes of schizophrenia in these populations. Another way of doing this is to look at see if there are sort of variables that can provide a clinical anatomical signature. So here, we're looking not at functional connectivity, but more structural connectivity. And likewise, you see that there are sort of three variables that kind of map along this kind of cognitive continuum, this cognitive negative symptom continuum, and they're associated with, on the section B here, they're associated with educational attainment, cognitive function, and negative symptoms. And what they're able to show is that, in fact, these can map into very specific circuits in the brain as well, shown here. And so if you look at this example in D, they're able to relate the latent variable, the pattern that they see in the structural changes in the brain with the pattern that they see in the clinical symptoms. And then finally, summarizing those in these two particular networks, which you may recognize are networks that were present in the last two publications that I cited as well. Lastly, in terms of brain imaging, can we shift from, okay, we already started with the category, can we move beyond the categories? And so this is work that looks along the psychosis spectrum. That means individuals diagnosed with schizophrenia, schizoaffective, bipolar. And here, you look at the positive symptoms. So one of the ways of thinking about psychosis, this is control, and these are the distribution of cognitive symptoms across those three different classifications, individuals along the psychosis spectrum. And what's either stunning or not stunning, to me it's still stunning, even when I look at this slide, if you ask the question, can the behavioral variation along that clinical continuum map into the brain, looking at a global brain connectivity signature, what you see is there's no real strong mapping between what we call positive symptoms and how the brain represents those at a network level. And in fact, nothing survives correction. If you then look at a principal components analysis and say, well, the psychosis configuration is real across all these three individuals, and ask the question, can we then look at a global brain connectivity measure to map those? And what you see here is profound mapping of the clinical behavioral variation into these cortical networks in this instance. And the details don't matter too much, but it's just to say that when you compare these two approaches, as you would imagine, you wind up with a psychosis configuration being much more effective in terms of relating to brain activity than the positive symptoms that we use as our clinical scales. Lastly, can we distinguish psychopathology without categorical designation at all, classification at all? And this is work where if you just look at all clinical questions that one could ask individuals who have schizophrenia, bipolar, or ADHD, what you see is actually you can identify transdiagnostic features reliably, and in fact with as few as just 10 questions. After 85 questions, the model starts to deteriorate. And what you see is you can distinguish the neuropathology or the psychopathology, but there's no difference between these groups. And yet, there are still features within each of those subpopulations. I'm showing you here the transdiagnostic signature with this spider plot, which is around social anhedonia and impulsivity. And then each of the three, schizophrenia, bipolar, and ADHD, they each have some of their own distinguishing features. So you see, for example, in schizophrenia, distress stands out, in bipolar, mood dysregulation, and ADHD, agitation stands out. So this is to say that we shouldn't abandon clinical instruments, clinical questions. The clinical symptoms actually matter in what we're doing, but what we should do is actually open the aperture a little bit and take a data-driven approach, whether it be from the clinical symptom side, the brain side, or a combination of both. So moving to wrap up here, I'll start by saying, and this is a quote from Edward Coles back, again, 100 years ago or so, one must advance from one formulation of tentative conclusions to another in progress towards the truth. Besides the symptoms of any present attack, we must take into account the course of disease, through the patient's lifetime together with the final outcome of the disease. And here I use, as a reminder, of two things. The first is classifications of disease are meant to be dynamic, not static, and we've lost track of that somehow. These micro refinements based on one modality alone are not sufficient. I've annotated this quote to put into the framework of diagnostic, mechanistic, and prognostic progress that we can make in understanding of disease. And if we revisit this triangle of insight, I think we could start to ask the question, can we look at brain-based categorization of subtypes of patients, and within those groups begin to look at fluid-based measures and look at differences there? Could we look at signatures of these symptom-based subtypes that I've shared with you and see if there's any fluid-based measures that can track with that? So the foundation is there, but it's not going to happen unless we really evolve our constructs. We need to move from these clinical groups alone to clinical biologically based subtypes. We could use that with identifying known biomarkers, suspected biomarkers, laboratory parameters, and ultimately move to these biologically defined clinical subtypes. And ideally, these would exist across ethnicity, across diagnoses, and across time. I think if we do that, and incorporate more accessible measures along the way, refine our understanding, again, just like we've done with Alzheimer's disease, not keep it static, keep it dynamic, then I think we really can bridge to a fantastic future. And the future looks something like this, where we used to have just clinical symptoms. Today we have brain measures. Tomorrow we can have fluid measures, all of which can come together for supporting mechanistic, diagnostic, and prognostic biomarkers. So what's it going to take? I hope you have a sense that it will require us to evolve our classification system for these categorical CNS conditions. We need to continue to identify these biologically based subtypes and or predictive markers of treatment response for major depressive disorder as well as schizophrenia, and begin to implement the transdiagnostic longitudinal patient cohorts with multimodal measures to really understand the course of disease and the relationships between clinical symptoms and biological markers. So hopefully you have a sense of why I'm so excited about where the field of neuroscience is. I think we're poised for true transformation in both diagnostics and therapeutics development over the next century. And I hope you'll join us in that journey. Thank you.
Thanks, Bill. That was tour de force. It was a great presentation, great way to start the meeting. So, how's that? Yeah. Okay. So we've got 10 minutes for questions. We've got some questions online. I've got a few that we could take afterwards as well. And I see some hands in the audience. So.
Let's wait for the microphone because we want the people in the virtual audience to be able to hear us as well. Thank you.
Bill, really enjoyed the presentation. In the outline, I'm wondering whether there is now the opportunity to have a forced category in the last slide that you showed, which essentially speaks to getting natural history of a population up to diagnosis. We have all the tools available, and I'm fantasizing, based on which we can get behavior and physical parameters, based on which better categorization can occur, and that can then be aligned with the parameters that you highlight. I'm thinking about track for 5 years how someone drives a car, how they get in trouble, where they go to the supermarket, what they do, where they go. What you need for that is volunteers that are willing to participate in that. And in some countries it is easier than in others, but if we had 20 million volunteers in the US, you would have a data set that would be outstanding. So, your thoughts?
Thanks, Lex. I think some of this is happening both in the US and in the UK. Those initiatives have kicked off where looking at sort of, I would say, healthy non-treatment seeking populations and a range of different sort of digital measures to begin to track this. I think it's a both and though. I think we need that, and we still need a framework in which we can place the data to form and test hypotheses. Yeah.
Tim.
I like the concept. The question is, does this change the drug discovery paradigm? In other words, do you have to go back and think of new ways of finding new drugs, given the way that you're going to develop them?
Does this change the drug discovery paradigm? Absolutely. I think otherwise we're going to be left in 1952, 1955, whatever it is. There has to be a shift in how we do this if we're to address the remaining unmet needs that remain across the populations. And so it's not just a change in the drug discovery paradigm, but the clinical development paradigm, the regulatory paradigm, and the commercial paradigm.
Larry.
So I think this is a extension of Tim's question. So as I understood your talk, the diseases will become rarer and rarer, and with full omics and all that stuff, and you will end up being in the pharma business unable to make drugs for the 100 people that have disease. So how do you deal with that?
Well, Larry, I think it will become rarer, but let's keep in mind where we are with something like depression, 17 million people in the US. If there are 3 biologically based subtypes, whether it's depression or schizophrenia, we can live with that. I think it's a route to, we hope somebody gives this talk, in 100 years, or their AI gives this talk, whatever, and they will see that this is the point in time when we have to go from one to many. What that many is, whether it's 3, 5, I take your point, but yes, it will become rarer, and yes, that should be okay.
Thank you for the talk. This, and maybe this is building on the other questions, but there's a very socially important meaning of diagnoses. So when someone gets a diagnosis like depression, they know that they're, well, maybe originally they don't know that, but then they start to look around and see stats and they can see that so many other people in the world are facing depression. And so would you suggest that the label of depression should actually kind of go away as we focus more on the biological underpinning of things and say, oh, I don't have a depression, I have a, particular brain circuit that's dysregulated, which kind of takes away some of the social meaning or some of the ability to relate to others as again, as they get rarer and rarer, it's like, oh, hey, I've got this dysregulated circuit going on. I just think that's different. And I'm concerned that it would eliminate some of the benefits of social support that people can get through that.
It's a great question. I guess what I would submit is that you might be overly generous in your interpretation of definitive depression, definitive diagnoses, that in fact many people will cycle through diagnoses, bipolar, depression, anxiety. So it's not like it's ever one thing anyway. That's the first thing. The second is, I do believe it's okay to start to talk about the biological basis of what you have. There's still, the reason I talk about the importance of institutionalization, of institutions and things like that, and medicalization, is because there's still people today who do not believe these are brain-based. If we have a heart condition, usually we can now talk about whether it's imaging or other fluid-based biomarkers, we can talk about what is the basis of that particular heart condition or metabolic syndrome or something else. So I hope we could move to accommodate both. I do take your point, and we spend a lot of time talking about this. We need to destigmatize these conditions. So the trade-off of the social value of belonging to something compared to the implications of actually being stigmatized for what you have, I think this is a balance that we need to strike. But moving towards something, I believe patients would like to know that they have a particular subtype of depression or their type of schizophrenia differs from somebody else. It's an assertion. I could be wrong.
So we've got a couple over there, but we've also got some online, Bill. So let me give you 2 online questions. So first from Ed Brody, who says, how do you imagine getting region-specific therapeutics with therapeutics that are not region-specific or known biological mechanisms? While you're thinking about that one, there's also a question from Richard Barker. Great talk, but fascinating to hear nothing about the role of specific neurotransmitters, to which I would add the end, Is the growth of neurotransmitter-based pharma work, is it over? Can we do something beyond neurotransmitters?
Well, a great selection of two questions that are, I think, interrelated. So to the first point, if we take a global brain connectivity approach and identify particular dysregulated circuits, there's nothing that stops us from mapping, for example, the transcriptome against those circuits. So we could start to ask the question, if we wanted to modulate a particular circuit, which mechanisms would we go after to privilege that modulation? So I think that's the first part. The second part is that might or might not be the neurotransmitter-based approaches that we've taken in the past. That's just a means to the end, and it's 2023, heading to 2024. So if it means that we have to embrace, the neuroimmunological aspects of these diseases in some instances, and think about different ways of intervening, I think that's something we should embrace.
And I think we were over here.
Hi, I'm Emmanuel Mignot. I'm a psychiatrist by training, but I moved a little bit toward sleep medicine. And one thing that struck me, I think, in your presentation is you're insisting a lot on circuitry, which I think a lot of people are nowadays. But I think one of the big weaknesses of the circuitry aspect is that you're really mostly studying, the cortical areas. And, there's not that much that can be done to look at subcortical areas. It's much harder, especially if you go lower and lower into the neuroanatomy. And I think that's a big, I think it could be a danger in some of those, direction, because it could be that the symptoms relate to some of this relatively superficial circuitry, but that actually the cause, the intimate cause, is much deeper. And in that direction, I really do believe that the genetics has still some quite good potential, because we have not been very good at doing interaction study to really do clustering and subtypes of genetic condition. And the advantage of the genetic is it's always causal. And of course, maybe potentially proteomics or things that are maybe a bit more biochemical. I mean, that's just an opinion, but of course.
So you're right. I mean, first of all, I think it's important to distinguish between a sort of clinical research agenda and an overall sort of treatment agenda, if you will. And I think that in advocating for a circuit-based approach, you're right that subcortical circuits are relevant, but usually they're still connected to the cortical regions. You can still pick that up. That's the first thing. The second thing is, by no means do I advocate for abandoning genetics or proteomics or anything like that. It's just to say that we need better refinement, biologically based understanding, brain-based understanding of those subtypes, and that's when we do the work in terms of genetics and proteomics to see what those relationships are. So I think together, if there's a takeaway that I would say is, it's meant to be multivariate, it's meant to be multimodal. I don't want to over-index on the circuitry. I think it's useful to do so right now because it provides a brain basis for subtyping.
So I think we better end this session now, but I'm going to take moderator's privilege and ask a question which I don't expect to be answered, but maybe we could come back to this later. And reflecting on how Larry opened the conference, this is really a question to the other Larry. So, many of the studies that you show here are using some form of AI, machine learning. Some of them use neural networks, but essentially, if I was to reduce them to the point where it's almost insulting, they're essentially correlational studies. Mm-hmm. They're clustering or correlational in terms of the underlying approach. But one of the things that we seem to be learning over the past 6 months or so, amazingly quickly, is that the generative large language models seem to be a different way of finding out information from complex data. So my question, which I guess we'll come back to in some way over the next 2 days, is when I look at your triangle and when I think about the multimodal approach and the data, is there some equivalent for us of the cat sat on the predicting the next word? Can we use these multiple data sets in a generative large language model informed way to actually get better at determining the information from the data?
Well, I love the question, the concept, and I think I talked about more accessible measures very sort of subtly, but I think things like speech right now, for example, where you can look at both the semantic content as well as the overall structure. I think this is when we talk about longitudinal assessment, this is something that's going to be critical, and we can relate changes in aspects of speech with other aspects of the disease. I think we might get to that.
It was a great start to the conference. Thanks very much, Bob.